why did we need a POGO? Well, we had 5 individual hospitals competing for resources and providing unequal services. If you went to Hospital 1, you got a different kind of treatment and different support than if you went to Hospital 2. Childhood cancer had been overlooked for years for all the reasons that I just pointed out. And so we needed a system that would do the following things. It would allow individuals to look beyond their institutional boundaries, look outward instead of in. It would allow all healthcare providers to help shape the future system. It would make access equitable. Every child in the province would have access to the same level of care, and that was state-of-the-art treatment. We knew that there were new diagnostic and therapeutic options coming down the line, and we also knew that if we went to try and fund those after they came, we wouldn't be successful. So we needed to plan forward. And we needed to engage the policymakers, the decision makers in the business of resources. Before we came into being, before POGO existed, this was the situation. There was an umbrella, a protective coat over cancer in the adult service. In all hospitals in the province, there was an amount of money and an amount of staff to enable there to be equal care. In the children's context, that was not true. We had different flows of money, and if Hospital 1 decided the most important thing was neonatology, it just cut its funding for oncology. And so it really was unequal, unfair, and didn't even follow the law. We said we need to take the what to people, and many of us here are the what to people, what needs to be done, and put them together with the how to people, the people who know how to make things happen. But we didn't speak the same language. We spoke medical, they spoke policy. What makes the difference? What makes the difference is data. Because everybody understands numbers. And to make this change, we had to be able to provide data, and the data couldn't be about one hospital or one tumor. It had to be about the system, or else it didn't make sense. So we sat down and said, okay, so what are the critical considerations for planning a system? Well, we know that they have small numbers and they are widely spread across a big province. The volumes are small. This is high-tech medicine, high-intensity specialty. It's not like many of the other more common pediatric specialties. We do big things to people. We knew the treatment is provided under protocols that are derived from clinical trials and complementary practice guidelines that also define how you should do what. At the heart of a system are specialist tertiary hospitals that require comparably resourced centers of expertise. But we also know that the people who live farther away from the centers lose income, lose time, suffer marital breakups, and in some countries, not so much in Ontario, abandon treatment. And there are reasons for that. That's not just that bad. People took me some time to understand how can you possibly abandon treatment. You can abandon treatment if you're having 2 children or 3 children, losing school and losing money. And we said our obligation for care does not end when the treatment ends. 5-year survival isn't enough. So what does planning require? It requires rationalization of services and centers of excellence. It requires regional coordination. beyond institutions and beyond parts of the city. It requires easy movement between institutions that do quaternary things. So bone marrow transplant, for example, shouldn't be done everywhere. But if you're going to place it in one or two institutions, it must be easy for children to be transferred. It needs access to pediatric subspecialties. It was our view, and it remains my view, that the day I am competent to look after an 80-year-old gentleman, my adult counterparts are competent to look after a 4-year-old child. They are not interchangeable. So pediatric subspecialties we thought was very important. Care had to be team-based and multidisciplinary, in part because this is more than a disease of genes or proteins or cells or arms or heads. It's a disease of all of those things, but it's also a disease of families and of society. And we needed to figure that out. We needed to build in long-term follow-up, and we needed excellent data for provincial surveillance, so we could know what was happening and whether we were doing what we said we would do and needed to do. And the key to that is collaboration, collaboration, collaboration. That collaboration needed to be within the professions, beyond the professions, and with a variety of stakeholders. So we created that collaboration, and out of that, the childhood cancer control system. We took as our base the 5 institutions in the inner ring that provide childhood cancer care. We brought in a group of community hospitals that were defined as having certain requirements. They needed a commitment, a money commitment. They needed a people commitment, and we needed to have enough kids to be able to care. And we brought in a group of institutions that could deliver long-term follow-up. Very importantly, this is POGO, and it is, you can see these are all circles. This is its own circle. And the reason it's its own circle is it must take the big view, not the institutional view. And that was really, really important. It took me some time to figure that out. Because I was the head of oncology, kids I wore 2 hats. So what is POGO? It's a stable, 28-year partnership. It is legally incorporated as a not-for-profit body, and it has registered charitable status. It can raise money for things it thinks it needs to raise money for. The fact that it is legally incorporated means that the people who work for it or who serve on its board must focus on POGO. It is supra-institutional. It doesn't belong to any institution. It is geographically separate. It has its own offices, so it can't be confused with any one of the bodies that it works with. It has permanent, fixed staff who are employed by POGO. That's who pays them. And there's an old saying in English, he who pays the piper calls the tune. You pay, you pay. It's funded by the Ministry of Health and Long-Term Care as its main funder. Other ministries contribute, the Ministry of Education, because of the things we do to kids with brain tumors, or the kids we used to radiate for leukemia, and perhaps some of the high-intensity chemotherapy agents known to be methotrexate. The Child and Youth Services Ministry contributes something because it understands that if these kids are not able to earn a living, they will become dependent on the state.